Recording in progress.
I want to welcome everybody back to The Broken Brain today. It's me, your host, Dwight Hurst, here again with you. We're going to have our weekly dose of mental health, and it's going to be a pretty good one this week. I've never started a show saying that I was anticipating it being a bad one. That'll be coming up next week. No, I don't know actually what's up for next week, but this one is definitely a good one. I am very grateful to be joined today by Dr. Marian Wilson, who is going to be talking to us about opiate addiction, opiate dependence. As anyone who has ever listened to the program knows, a very, very important topic that we talk about a lot on this program. And she was kind enough to come on, and she's got a lot of experience in this area in both clinical practice and academics, and you're going to tell us all about that. But Dr. Wilson, thank you so much for being here.
Thank you for having me. I appreciate it.
Tell everybody a little bit about yourself and your background, and what kind of stuff do you get into?
Okay, well, I'm a registered nurse. I've been that for quite a few years and have done a lot of different things in settings, both hospitals, out of hospitals, home care, psychiatric settings, behavioral health, residential settings, lots of experience in the clinical world until I somehow got lured into academia. And so for the past 10 years or so, I have been mostly teaching and conducting research. My area of interest is about people with chronic pain who are prescribed opioids. Sometimes those are people with an opioid use disorder, not always. There's a lot of gray area, and I hope that's a little bit of what we'll be talking about today.
It's such an important crossover here because I think when we look at what opiates were designed for, one of the things that we sometimes leave out of the discussion with opiate dependence is that, so much of opiate use is done by prescription. And also when they were designed, there's a lot of ways in which they were designed very successfully. And so we leave out the fact that sometimes with pain management, they can be very effective, but then also have a lot of problems associated with that use. And I'm excited to get into it. I'm fascinated too by your background. I have found that anybody with, whether it's academics or prescription or anything, with a background in nursing, that's such a hands-on background. That's such a hands-on approach to things. And I guess I don't know, I just find that helps. I refer most of my clients that I work with to go to a few different nurse practitioners in the area as far as psychiatric specialists. I find that even that they tend to listen even better than medical doctors. So take that, medical doctors. Just kidding. A lot of medical doctors come on the show too. But the nursing background is such a powerful part of things, and it can't help but shape how you look at things, I find anyway, as a non-nurse observer of nurses.
It is a huge part of my identity. We are trained to be great listeners. We're trained to be patient advocates. And I feel like all of the research I do is just trying to be a voice for those patients who aren't heard. So my research focuses on generally stigmatized populations and trying to tell their stories and help people understand what some of their struggles are and avoid stigmatization and judgment and those kind of things. As a nurse, that's one of the things we try really hard not to do, and we're not perfect, but we definitely want to be that patient advocate and help to avoid stigmatizing language and behaviors and those kinds of things.
Well, and I'm excited to dig into this. A good place to start might be right there with that stigma. When there's a stigmatized population, addiction and dependence already have a lot of emotional landmines and stigmatizing types of labels and behaviors that we do as society towards those that are struggling with it. But then we're throwing in this other part too, which is if you're taking prescription opioids and opiates for whatever, medical designated problem, I feel like one of the problems is people have a stigmatized view, kind of almost either direction that can hurt, where there's shame association with medication and people kind of downplaying that. On the other hand, then sometimes there's also the other extreme where people feel like you shouldn't take medication. I don't know, like these medications shouldn't be used at all. And I'm interested to hear some of your thoughts about that, about how the opiates are prescribed Particularly, we both live and practice in the U.S. here. Of course, you have access to all kinds of data and stuff. But what are some of your feelings about the use of opiates in the medical field?
Well, I've given out a lot of opiates in my day. I started out working in acute hospital settings, never thought twice about giving people opioids. And in fact, we were taught when I was first started to tell people, don't worry about getting addicted. When you use opioids for pain, you can't become addicted. I know there's still some healthcare providers saying that today, even though we know that that's not true. We know that everyone is at risk to develop a substance use disorder, including people who are using opioids to manage their pain. So I've given out a lot of opioids. I worked in oncology for a decade. And again, I love the fact that we can help people get through the end of their life without suffering because of opioids and sedatives and all the great concoctions that we have. So I'm a big proponent of them in the right situations. It really came to light for me when I started working in research projects that there was this conundrum for people with long-term chronic pain. And one of the very first projects I did when I was just working on my master's degree was helping to analyze data for a pain management program that was centered in an emergency department. And part of what they were doing there was trying to get people not to come to the emergency department for their pain care needs, specifically to ask for opioids. So they had an algorithm and they tried to refer people to primary care or to pain specialists. But the bottom line was, we don't want you coming to the emergency department if you have chronic pain. We don't do that here. And we're not good at it. So at that time, my eyes were opened because I started to see the stigmatizing attitudes towards people coming into the emergency department. And I really felt a lot of empathy for those ones that I knew had chronic pain conditions and they just didn't know what to do. And that's why they were showing up there, but they were being treated the same way as someone who might have been there. Malingering is a term you might use, like not really having a pain condition, but maybe they were getting the drugs to sell on the street, or they were getting the drugs for, other purposes in order just to have that high, that euphoria. So really hard to sift and sort through those people coming to the emergency department, some with real legitimate pain needs and others with less legitimate needs. Mm-hmm. So one of the things that I saw at the same time in the community, more news about people breaking into pharmacies and breaking into physicians' offices. And my own physician even put a sign on the door saying, we don't have opioids here, or we don't have narcotics here. I can't remember the term they used, but I asked them why they put that on the door. And they said, well, we see all these break-ins. And so I started thinking about these people being turned away. Even if they had an addiction, they were being turned away. And where were they going? They were going into the community because their problem wasn't solved. And that really started, the past decade of research looking at people with pain and people with substance use disorders who also have pain.
It's interesting because you're talking about a differentiation that is already difficult, but of course then the population isn't really necessarily a completely 100% distinct population that we're talking about there either, too, right? Because many people that are what you might call malingering or drug seeking behavior or that type of thing, a lot of times that's also to treat pain, which is the pain of dependence, right? Which is that kind of thing too, where there's not necessarily going to be a difference in even the internal belief system of what I'm after right then at that point. So it's not just a lot of crossover there. And then again, of course, a lot of people, when they are abusing opiates, do have chronic pain or other health conditions that they might not be aware of or that they might be self-medicating for too. That's very, very tricky. How do you differentiate populations that actually coexist and cross over each other, right?
Right. Yeah. And we have a lot of mental health problems too. Depression, anxiety, post-traumatic stress disorder is a big one that people often will develop both substance use disorder and chronic pain. So there's a lot of crossover there. And yes, it's very difficult to sift and sort. And I would say anyone who shows up to a clinic, an emergency room, a physician's office, and they're asking for opioids, they are in a crisis. You may just not know what the crisis is. Even it's because they sell the pills to pay their rent. They're in some kind of a crisis. And so we have to look at it that way and figure out what is the crisis they're here presenting with today and what are the proper resources.
That's interesting. Really important differentiation, I think, because you're looking at it like someone didn't wake up one day and say, here's my plan. I'm going to maliciously plot my life to where I'm going to need to obtain opiates to sell to pay my rent. No, it's like that's still a crisis. And there's a compassionate and also appropriate like medical labeling of that. I do think that even within the field, sometimes we forget that addiction isn't just a morality or behavioral problem. It's a medical problem, right? And like so many leads to us having different judgment and different types of decisions that we may make. And of course, we all have, elements of our own choices and whatever that we have in our own health management. But it's fundamentally, we're talking about, from treatment perspective particularly, it's a medical problem if the person comes in and does something like that.
Yeah. And I will say, I don't consider myself an addiction specialist. I feel like my specialty area is pain. However, I've been around a lot of substance use disorder throughout my life, both personal life and professional life. And so I feel like I have a good understanding of what happens when a person has a substance use disorder is their brain is hijacked. They are no longer making rational decisions. And I just saw a presentation yesterday that really left an impression on me. They were talking about the xylocaine that's being now put into the street fentanyl, and they call it the zombie drug. I don't know if you've talked about that yet on your program, but it would be a great topic.
I haven't. Yeah. Tell us about more.
Well, someone shared a picture of what happens when you use this drug, and the xylocaine is added to the fentanyl because it gives a longer lasting high, supposedly. So you get more bang for your buck, so to say, out of that fentanyl that a person might get on the street. However, it causes these massive leg ulcers or skin ulcers. And they showed a picture of it and it looked terrible. It looked like zombie Walking Dead kind of a picture. And I could see some sort of gasps in the room, people just like, oh, those people, how could they take this? Even though look at their leg, and how could they continue to take this medicine or take this additive with their fentanyl? And, I thought, that's the unfortunate part about substance use disorder is that you don't get to hide your addiction so well sometimes, and all of us, I will speak for myself. I have a very hard time like driving past a Dairy Queen and not stopping. I mean, that's my thing. And fortunately, I don't live close to one, so it doesn't become a huge problem. But, we all have certain behaviors where our brain is hijacked. And I think for people, certainly taking a drug that's going to give you massive ulcers on your legs, it's going to be hard to hide that. And so to me, that's where some of the stigma and shame comes from, is just how well can we hide our addictions? So anyway, food for thought.
Great point. No, a really great point. My daughter used to work at Dairy Queen. And in fact, she still likes their chicken strips basket. So I go go through the drive-through at Dairy Queen when I'm taking her to her current job. Yeah, quite often now. Geez. See, I've got to think of it that way now when I go through it next time. One of the things that I often think about is the fact that everybody has, as you put it, their thing and their addiction of choice, or their addiction of experience, the things that we each have that are compulsions. One major difference with chemical addiction is that it was taken over, the care of which was taken over largely by law enforcement years and years and years ago, because there wasn't yet the technology or the acceptance of it being treated within simply the medical world, right? The behavioral problems that come from it have been treated by that. And so if I'm having too many blizzards, for example, nobody's made that illegal. And there hasn't been a reason to turn that over to the cops to come and police my Dairy Queen usage, right? Or whatever it is for a lot of those things. It can still have health effects. Any of our problems can, but we don't have the same amount of shame, because if you can joke about it with friends in polite company and you don't have to worry about being pulled over or jailed or something, then there's not that social stigma with it the same way.
So true. And I wanted to get back to your point about the medications for addiction treatment, because I think that's another area where there's a lot of confusion and stigma. And from my perspective, from what I've heard and talking to people who are receiving daily methadone, for example, that allows them to go back to some kind of a normal life. That's what that does for them. And it's a very difficult thing to go through. I actually stood in line in a methadone clinic when I was first starting my research in that population. I wanted to find out how many people here have chronic pain, how many people started their problem with addiction from a pain disorder. And so I was standing in line the first time walking in the clinic, and everyone else is in line too. And you can see who they are. And, some of them might have a hoodie they wear and try to sort of not show their face, but they don't have privacy. And I thought, how terrible that would be if I had to do that every day. Or let's say I had diabetes and I had to do that in order to get my insulin. And so right away, I was really feeling a lot of empathy for the people that just have to show up every day to do that in order to feel normal. We did some interviews with people who said that they ended up in methadone treatment after getting opioids for the first time for a painful condition. And they talked about how it went from, just using the medicine to treat their pain to a point where it was maybe they were using the medicine for other reasons, maybe to help them sleep or to help with their anxiety, something other than just the pain. And pretty soon, because opioids do make you develop a dependence, you are going to have withdrawal symptoms, even if you've only been on them for a few weeks. Withdrawal symptoms may start if you've been taking it around the clock. You're going to feel bad. And so you're going to be compelled to have that opioid so you don't feel bad. Yeah. And they talked about there being just this turning point where they knew that they couldn't go back to just taking it occasionally or just taking for pain. It had really taken over. It was a compulsion, a craving that they couldn't stop. But getting back into treatment, they talked about how that just allowed them to get back to some kind of a normal life where they weren't constantly thinking about where am I getting that opioid from. And so it's just really interesting to see how that develops. And I don't think we really understand fully how that does happen, but we do know certain people are at greater risk for that to happen. And we can at least warn them up front with that very first prescription. This is something that could happen to you.
Yeah, I have often thought that it's a terrible type of judgment when I've worked with people who have used methadone or Suboxone or those medical interventions to cut down on dependence pain and to cut down on cravings and relapse likelihood. It's such a huge boon to people to be able to do that and to have their lives back, as you put it. But I talk to people who run medical detox, and they say they always run into this where there's still a perception out there that people think that somehow that's cheating, that somehow you're just still using drugs. But it's like, yeah, the way that we all do when they're when you're prescribed a drug that's meant to help you in a way to get off of addiction. There's a judgment that is still there for that. And so, as you put it, yeah, that waiting in line, or many of those clinics are only open at very early hours or weird hours, so people can still try to keep their jobs. And then even sometimes even 12-step communities will give people a hard time for that type of thing and say you're not really in recovery until you kick. And they use these kind of terms sometimes, kick the methadone or something, instead of like, well, how about if I reduce my dosage over time as appropriate as determined between me and my physician, and perhaps my substance abuse counselor can help, with me to work through those things as well. So we don't, that's where that stigma really still comes in and is really, really heavy. But it's really a grateful thing, or really grateful for the opportunities we have to have those things available. When you look at that and see how many people get into the world of addiction through chronic pain, I wonder then too, do you find that too when people are coming off of and they're getting into recovery for opiate abuse? Oftentimes that's been a long time coming. If people have been using for long enough, they might find that they have health problems and that they have pains and things that come up that they didn't know they had while they were abusing drugs.
Yes, I think there's so many things to unpack here, but when they do decide that they don't want to use opioids anymore to manage their pain, it's going to be pretty hard to transition to an opioid-free lifestyle. And that will often require some tapering, and it has to be done very gradually. One of the big concerns that happened. In 2016, the CDC put out some prescribing guidelines for opioids. And at that time, they were really encouraging providers not to give out opioids, particularly for long-term use for chronic conditions. Unfortunately, those were interpreted very strictly by many clinics. And so people who had been getting opioids for years, all of a sudden were being told you can't have them anymore, or you can't get them here, or a doctor would retire who was giving them the prescription and they couldn't find another doctor to pick them up. That's still happening now. The newest guidelines that came out in 2022 are emphasizing that those guidelines should be person-centered, meaning that we don't treat everyone the same way. We have to see what the person's situation is. In some people's case, it may be appropriate to continue a long-term opioid if that is the only thing that's going to help them with their quality of life. I don't know if there's a lot of research on this, but I'm really curious about people who may have an underlying depressive disorder. And the first time they actually might feel normal or feel good is when they get that opioid. Mm-hmm. And so for those folks to think that I'm not going to have my opioid anymore, it's not just about their pain, but it's also about their ability to feel enjoyment in life. Mm-hmm. So, there was at least a study where they were using opioids for severe irretractable depression. And so I think we have to consider that too. It's a very serious thing when people go off of opioids, and to stop abruptly is actually quite dangerous. So that's the other message that I have, a public health service here. If you know someone who's been on opioids for a long time and they're being told they can't have opioids, or they're being cut off abruptly, that is a medical emergency. And we have things that we can give people to transition them through that period of time. Or they may be a person who really needs to be on medication long term, because, as you mentioned, returning to drug use is very likely to happen in people with opioid use disorder, and it's more likely to happen if they don't have a medication to assist them. So the judgment about taking the medicine is really unfair, because it could be just a matter of life and death for a person. Some people can transition off the medicine. They're fine. Not everyone. Mm-hmm. Some people are not going to be. And to push people into that could be just pushing them into suicide, homicide, severe withdrawal. We have evidence for all of this happening when you cut people off abruptly from their opioids.
And it makes people feel so disenfranchised, not just in the addiction part of the pool, but even with chronic pain. I mean, isn't that an area where people have felt disenfranchised historically as well? You hear all the stories of people who are, over the years that get told things like, well, this is all in your head is a terrible phrase, for example. Well, number one, because everything technically goes through our head. I mean, I don't know if people realize that, not to be too medical here, but the brain is located in the head, and it is responsible for relaying all of our sensory experiences, right, throughout our body.
Yes, I say that. I say it is in everyone's head. If we didn't have a brain, we'd have no pain. So it is in your head. And that's actually why some of the non-opioid options work well, is because our brain can actually be retrained to process pain differently. That's the good news, is that there are things that can be done. They're not as accessible as they need to be. They're not being offered to patients 100% of the time the way they should be, but there is a lot of hope to be had.
It strikes me, I wonder what your feelings are about this. It strikes me as kind of a cop-out to, if the two options are either, well, I'll just prescribe opiates in a way that's kind of like lazy and reckless, or I will refuse to do it because of some like over-rigid interpretation of this and paint with those two broad brushes. That both of those seem highly inappropriate to me, like a big cop out on the part of the treatment side there, right? To say like neither of those is meeting the needs of probably most patients.
Yeah. So the good news is there's been some changes in legislation just recently. Anybody with a DEA license can now prescribe medications that help with opioid addiction, buprenorphine, for example. They can do that now, and there's no cap, no limit to the number of patients you can treat. There used to be a waiver that you had to do.
I didn't know that. Wow,
that's very recent. Yeah. It's gone away. And part of this is because the other key point that I wanted to get across today is that all of these medication options for addiction treatment are underutilized. And I'm talking about for alcohol use disorder and for opioid use disorder. We have medications that absolutely can help people stay away from using these substances. but they're offered a very small percentage of the time, and they're just not used to the capacity they could be. I think in part because a lot of providers don't feel very comfortable with it, or they feel like that belongs in the hands of the addictions professionals. And then, as you mentioned, there's some addictions professionals who don't believe in using medicines. They think abstinence. There's plenty of treatment programs that are detoxification programs where they're just trying to get you off of those substances. And often people have to go back repeated numbers of times because that is not going to be successful for them. Yeah. That also, I want to add, is when many people die, because when they leave a program and they've been through detoxification, they go back out in the community and they use a substance and they've lost their tolerance to it. So even if they use the same dose, they might overdose and die. Mm-hmm. So it's pretty serious business, this notion of telling people they should just try to be abstinent.
Yeah, it's and it also does not work well with research and even reported experience. When you talk to people, I have a hard time. I'm a harm reduction oriented type of therapist myself, but to me, harm reduction is just the definition of medical. Like if you're going to approach addiction with any kind of medical treatment, harm reduction is simply the discipline that says you meet the patient where they're at, you see what their goals and needs are, and you work from there. And if you're a treatment professional, I don't see how you are anything else. Now, if there's a philosophical model, and I know there's support groups and things that are out there that are like, oh, we have a philosophical model of abstinence. To me, that's philosophical. But in a medical, the insistence of a one-size-fits-all treatment is silly, unethical, and dangerous, as you put it, the most important word, which is it kills. It can kill people. I think that there's an importance when people are looking into detox nowadays that they find a place that is a medical, modern, research-based detoxification. I'm able to work with there's a program called the Wiseman Method in Los Angeles that I help them with. They produce a podcast that they do about detox, and they won't even begin the process. Part of the assessment to see if someone's a good candidate for medical detox is they have a thorough medical examination. They determine, is this person safe to, get off of opiates first? What are we going to do to make sure that they're safe before, including underlying health conditions? And once again, I guess I keep harping on this idea of treating it like a medical problem, not just like a stop it kind of problem.
Right. And we've made that transition for some things, like depression is an example. We find that medications are helpful, so we don't tell people to just snap out of it and cheer up. We know that for some people, they have to have that little medicine extra bit to help them really meet their treatment goals. It's no different. You've got a major physiology problem going on here of some kind. That's like I said, I just think of it as the brain being hijacked. The brain is going to do what the brain's going to do. So we need to give the medication so we can get some control over the situation here. Then we can work on the, building healthy social supports and behavioral therapy and all of these other things that might help people be successful. And some people can be very successful without using medications, but it should be offered to folks. And I agree with you. I think we need to have treatment programs that embrace this as an option for people to allow them the best opportunity for success.
Mm-hmm. What about people who have the chronic pain, but then have a history of addiction when they have gotten through that? I know that's always been very, very difficult for people when they're in sobriety and they haven't used anything for a long time, but they still have to manage chronic pain, or, sometimes they have a resurgence of whatever the condition was in the first place. So they get into that where it would be appropriate generally for them to use opiate-based medication. What have you found with kind of the research in that area? What are guidelines or things that they need to keep in mind?
Well, I don't know that I know that much about the research. I don't think there's a lot about that specifically, but I will say, just as a clinician working in hospitals, I know plenty of patients who have expressed fear, even if they have a terminal cancer. They're so fearful of taking that opioid because they've had a substance use problem in the past. And maybe it was an alcohol use disorder, not even an opioid problem, but they're fearful of trying any substance because there's a lot of people that are very successful, even without medicines, and stay away from their substances. for many, many years. So it can be done. And then when you're presented this opportunity, maybe you have a disease or you have to get a surgery and someone offers you an opioid, you're very nervous to take that. And I would just say, I think they're right to be nervous about it. And you have to use these things judiciously. And they really should be used that way anyhow. Because, for example, when you go to the dentist and you're going to have a tooth extraction, they'll sometimes send you home with a bottle of pills. And for many people, they really just might need some anti-inflammatory. And they can get through that first 24, 48 hours. They might not need an opioid, but I know as recent as this year, I have people telling me this all the time, how, oh, my doctor gave me a whole bottle of hydrocodone, and I didn't take any. Yeah, that happens. So I think, we have to look at every person and situation before that prescription is given, before that pill is given. Let them know they're probably not going to have a return to drug use from using some morphine because they have a broken leg for a day or two. But if it's sustained over a week or 2 weeks, that's when you may start to develop some dependency. And it's, I don't think it's irrational to think of that as potentially being a trigger for someone.
Well, and you think about it, it's a good, healthy practice to think twice about anything that we ingest, whatever that means, right? Whether it's the prescription or the blizzard or whatever it is, whether or not, and in some ways, the decision-making process is as important as what it is we choose to ingest. You mentioned PTSD, and I guess, first of all, I'm just curious how you see the quarantining and the pandemic having affected some of these dynamics, and what have you seen activated there?
Yeah, definitely we're having people struggling with mental health challenges, and the pandemic didn't help that any. If you were already at home, probably about a third of people in my pain studies are unemployed, on disability, not getting out of the house very much. And I know we actually had a study going on at the time. We were going to be bringing people into a clinic and having them try different non-pharmacological options. We ended up having to do it all by Zoom. So they had a yoga therapist, a massage therapist, chiropractor, and a physical therapist, all through Zoom consultation versus hands-on. So we were happy we were able to provide something, and we learned a lot.
Wow.
Some people benefited just because the education provided by these really expertise practitioners was so helpful to folks. But we heard about them saying things like, well, I usually go to a yoga or I usually go to a swimming pool and I can't do that right now. So we know it affected people with chronic pain who already were trying to manage their pain by doing a lot of different activities. I think that's another misconception, is that all they want is a pill. Mm-hmm. I actually heard this from several providers when I was recruiting for my dissertation study. I was trying to engage people in an online pain management program, and several providers said, well, I don't think anyone's going to do it because, really all they want is a pill. And I think that's a misconception, because most people, what they want is they want their pain to be relieved. And so if it comes to them in a pill form, that's great. If you can figure out some other form, they're happy with that too. And so providing options and helping people understand how to access those options is another area where we could do better.
And talk about an incentive, creating incentives then, or some kind of maybe the understanding of need for physicians to get to know their patients a little better than, from what you just said. People saying, oh yeah, no, everybody just wants, and I've heard things like that from prescribers sometimes. And it's like, well, no, look what we did. And they really seem to appreciate it, didn't they? Because they're people who actually just want to live and feel better,
Yes. Another thing we learned, this was a little demoralizing actually, because I've been doing this research now for about 13 years, and we did focus groups with people with chronic pain, trying to understand more about their unmet needs. And I was hoping to hear that things were a lot better now, because we've had a national effort trying to make things better. But what I was still hearing were that many of them, they had never even heard of a pain psychology approach. They had never been referred to a psychologist. They didn't know what pain self-management was. They hadn't been to a pain self-management program. So there were still a lot of things that we know from research are absolutely helpful, and they're not getting to people. Whereas the prescription is, maybe it's there, maybe it's not, but these other things that could be helping are not being delivered. So that is really my next goal, and what I'm focusing on for my research right now is just trying to make these things accessible that should be freely, in my opinion, we can get into a whole discussion about universal health care, but if we just talk about
I'm on board.
If we just talk about substance use disorder and mental health, if we would just agree that we could give these things, these tools to people free of charge, we might have a lot less, shootings happening, suicides happening, suicides are up, shootings are up. Yeah. Can we just agree we'd like to address the mental health crisis and not charge people for it? Because most of these folks can't afford it. They can't afford it and they need our help. And it would actually make our society a whole lot better if we would provide these things for people, high quality, evidence-based mental health and substance use treatment.
Well, you think about what the cost is of the consequences of untreated mental illness, untreated chronic pain, and exactly, it's not even a consideration if we were to do the math on it. The people who like to point and say, well, what's the math on that? Well, it's extremely costly to have people wandering around in our world and society who are hurt and hurting and hopeless, and feeling hopeless and all of those types of things that just compound upon themselves.
Yes, and I'm glad you included the chronic pain there because I don't consider that a mental health condition, but it certainly has mental health components. Yes. And, find me a person with poorly managed chronic pain who isn't depressed, and I just will be very surprised.
Yes, you're right. Exactly.
Yeah, we also see people who, some of the shootings that have happened to clinic staff, if people have been denied their opioids. So we have aggression in our society, promoted because of this lack of resources for people who there are things that could help them right now today. I can't fix everyone's pain. I can't make it be less hurtful, perhaps, but I absolutely could help everyone make that pain interfere less with their life. That is something we can do. And so I think that should be delivered to people, anyone who needs it.
Yeah, absolutely. That's kind of key to the process too, right? Is my understanding is the proper definition of a goal. As you just put it, it's not the cessation of pain, it's more the reduction or the management of pain.
Yeah, I always remember these couple of participants who I was trying to recruit to one of my first studies, and they said, well, I like what you're doing. I'm glad you have this study, but I can't join because if you're asking me about my pain all the time, it's going to get worse. I've already learned how to put my pain on the back burner. And so I can't join your study for those reasons. And I was just like, thank you. I want to study you people because you have figured out a way to put it on the back burner. And some of the things that are coming out now, like the pain reprocessing program that's going on out of California and some others, it really is about training the brain to reprocess those signals that are coming in. And it's not going to be maybe as simple or as quick as taking an opioid, but for some people it actually can be quite quick, so there's hope there.
Well, and it doesn't have along with it the risk of the opiate-based analgesia where your pain is actually provoked eventually and it stops working. And can you tell everybody a little bit more about that, the pain reprocessing program, for those that aren't familiar with what that is?
Yes. Well, I'm not an expert, but I have read the research on it and it's very encouraging, and I read the book, and I don't know if you've had that person on your show, but it would be great to interview the person who wrote that book. But it's just talking about, basically when sensations come up, you're addressing them and you're feeling the sensations and you're changing your way you're interpreting them. So it sounds like a lot of hocus pocus, I know, but the research is there, and the people that know how to train folks to direct those pain messages elsewhere, they really can have great effect. And even as simple as what I said, putting it on the back burner, diversional activities. We've always done that in nursing. We've always helped patients with their pain by turning on the television, having a conversation, reading a magazine. It's really hard to focus on your pain when you're doing something else. Your brain can't concentrate on both at the same time. So there is science behind it. There is benefit. I wanted to go back though to what you said about the opioids becoming less effective, because I think that's another issue that when people receive an opioid, it should be decided at that time that there's nothing else that might actually help. And that's your only option, because we do know that over time, it's going to require more and more to get the same effect. And that opioid is not actually fixing your pain. It's not fixing the problem. It's only masking the problem. So for example, many years ago, when I was a nurse, I had to do a lot of lifting in the hospital and I was having some back pain. I went to my doctor and I asked what could be done. And she didn't whip out her prescription pad. She actually sent me to a Pilates instructor. And what the Pilates instructor showed me was that I had a posture that was really exacerbating my lower back. I had 3 sessions. I paid for it out of pocket. But it took 3 sessions and I learned the problem was caused by the way I was using my body. That's just an example of how pain can sometimes be something we're doing and something we can change and I could have just taken an opioid and the pain would have gone away, but that wouldn't have changed my posture or the things I was doing to make my pain worse. So I think that's really important for people to understand.
Or imagine too, if you didn't have the access, whether it's insurance, whether it's money, or even just the time and inclination that people have to go and get the proper like medical feedback. And a lot of times that also goes back to what kind of relationship have we had with medical professionals in our lives, right? If it's someone who doesn't, so in other words, who just doesn't go to the doctor and just takes a lot of ibuprofen, and you talk to people who've been taking ibuprofen or Tylenol every 4 to 6 hours for 10 years or more or whatever, it's just, this is just part of my everyday as I'm just slamming, like anti-inflammatories over the counter, thinking that that's cool and fine or whatever, when it's like, and actually if I had 3 sessions with this proper person who could tell me something, that would correct the problem largely and not need those things and then not be inflicting continuing damage on the body. That's a huge difference for what is essentially not a lot of time invested in the correct area. Does that make sense what I'm saying?
Absolutely. And I'm glad you brought up ibuprofen because that also has lots of risks. And I've taken care of plenty of people, with bleeding problems related to ibuprofen. So I think these things we buy over the counter that seem very harmless, anytime you're taking a pill to mask a pain and you're not actually getting to the root of what that problem is, that's not a good solution. Now, if you've already been through the ringer and you've had a diagnosis and people know what it is and it still hurts, yes, then, that's what medicine is for your quality of life. But it shouldn't be the first thing you do.
That's exactly how we use it, though. Right? Especially non-medical professionals, and I say especially because medical professionals are, we're those anyone who works in the medical field is kind of famous for like lack of sleep and all those kinds of things. So I'm not trying to make it sound like, but with even. Especially without the knowledge that you just said, right? We grow up and that's our societal instruction with what is in the medicine cabinet. That's why it's there. It's the first thing we reach for, right? Is that, I have this pain, I'm going to get that. And if it's a recurring pain and my recurring reach for the medicine cabinet, I'm not finding that root cause, as you put it. It's an interesting idea. It's even just it's like thinking strategically about the pain that we experience. As you're describing that, I'm thinking to myself, like, gosh, do I even know what, if I get up and I go, ow, what do I do next? Do you know what I mean? What's the healthy thing to do next? What's your thought about that?
Yeah. Well, I'm a big believer in yoga, for example, and physical therapy, for example. But these are also areas where you have to stay with it usually. So a lot of the pain that we have, musculoskeletal pain, and I'm guilty of this too. I have a computer-based job. I'm on the computer all day long. We get into very bad postures and tension from that. So if we're not doing something to reverse that, we're probably going to develop some pain, or carpal tunnel syndrome. That's another one. If we're typing a lot of the time, we're probably going to get into some pain. Yes, you can go get a surgery for that, and that might fix you. And for some people, that's what they want to do. But to me, that's part of our societal teaching us, like the way that we deal with problems as we go to the doctor and get them to fix it. And things like yoga, if we look at cultures that have been using yoga for a long time, most of their older people are very limber. They're in pretty good shape. Some of the countries where you have open community, Qigong, Tai Chi, and people are doing those things on a regular basis up into their older age. They're staying mobile, they're staying limber. So our culture doesn't have that. So we're at a loss for that. Physical therapy, I love physical therapy. I think they can solve so many of the problems people are having with pain, but it costs money. And you usually have to keep going or keep doing those exercises. So as soon as you're done with those sessions, often that pain is going to come back unless you continue doing those exercises. So, am I going to do all that, or am I going to take a couple Motrin and, have it taken care of? So these are the issues. We have to make the choices.
It's a very interesting strategic vision, purposeful way of making the decision versus just reactive. Because a lot of times I believe that many of our ongoing problems with health, with addiction, with mental health, really has to do with the need that I have to be back on track sometime in the next 10 minutes. In the next 10 minutes, I got to be back on track to get the kid to school, to get to work, to get to run this errand, to get to pick up this thing or do this or, whatever it is. And the being in a hurry and being locked into that really does, especially these kinds of these kinds of small, repetitious re-injuries that we do to ourselves, psychologically, joint-wise, cardiac health. I think cardiological, it's easy for me to say out there, everyone, cardiological health or whatever it is, those kinds of things that we damage and re-damage just because we're in a hurry, And
so we didn't really get to the PTSD, but what I wanted to say that was a lot of, I was thinking of it because what you're talking about is a stressful world. We're living in this kind of self-inflicted, stressful, busy world where we don't really have time to do stretching in the morning and eat properly and walk a lot. We don't walk a lot. Cultures that walk a lot are doing better than we are on all of these things. So with PTSD, I think sometimes it's just underappreciated when people show up for that office visit, that emergency department visit, and they have a history of something that was traumatic. We're not uncovering that. And so we're not treating it. We're treating them for the superficial pain or even addiction that they're coming in to tell us about today, but we're not really uncovering what started that and the trauma that might have started that and the patterns in their body that began because of that. We know from children who have suffered abuse, there's a way of responding to stress that is a very physical, emotional, mental kind of an experience, and it's a pattern that you're living with. We don't spend the time talking to people about that and helping people understand that that's even a thing that happens to people. And that may be why you're having chronic pain, because you had traumatic things in your past and your body learned to respond this way.
Yeah. Well, there's a lot of information to tap into here. One of the major messages I'm getting from what you're saying is trying to get to know ourselves and finding those purposeful and proactive ways to manage things. Like you said, can I add or integrate some health management, yoga, stretching, those types of exercises? And it's amazing how much even just a little of that will help a little, and a lot of it will probably help a lot, right? So, and I think the payback that we get from those kinds of things will be is quite high. So that's a wonderful thing, and it's really helpful to people out there. I wanted to ask, I always give everybody a chance to share kind of where people can find their work and what they do. Before I ask you that, though, I like to ask people if they have any kind of a community, charity, nonprofit, any kind of thing that you encourage people to investigate, to get involved in for their own volunteerism, their own, community-oriented give back kind of feelings. It doesn't have to be related to what we're talking about, but it can be. Do you have any?
I love that you're asking me. Yes. Yeah. So I think, as I was mentioning, the yoga therapists, the massage therapists, the physical therapists, the chiropractors of the world, they have such knowledge to share with people. And if they can find it in their hearts to do some pro bono work, to offer some coupons to people in pain, mm-hmm. I just think it will do a world of good because, and I'll put psychologists in there too, because I do know that having a good psychologist who understands how to manage pain is something that's not accessible to people. So if you're presently not reaching out to people who are underserved, if you could do that, that would be awesome. Mm-hmm. We do know people with substance use disorder have a lot of pain. 60 to 80% of people with opioid use disorder have a comorbid pain condition, and they're often not treated for their pain. They are treated for their substance use disorder. So there's a big gap there. So I'll put that plug in.
Oh, excellent. Yes, that's a great way for people to give back. And, as you said that too, it makes me think about all those people out there. If anyone out there is one of those professionals, that's a great way to give back. If you are not, but anyone who is, or I know a lot of people out there who are involved in yoga, for some reason just popped in my head, who are involved with maybe they're not an instructor, but they're involved with a studio and they have some kind of like teaching experience with it or something. And there's a lot of matching up people with those services that that you think of. Yeah, that's great. That opens a lot of doors in my own mind of ways to help people too. So thank you. Well, where can people find your work? Where can they track you down? I didn't mean that sounded a little creepier than I meant it to as I was starting to say it, but where can they find you online?
Well, I work at Washington State University. I have a bio page and I can show you some of the research that I've done. I have an email there. People are welcome to email me. And let's see, I'm on LinkedIn. You can find me there. So yes, happy to communicate with people and just talk about. I'd love to hear from people who are struggling with pain, and often they have solutions that aren't being researched. So some of our best research ideas come from people who have just experimented on themselves and figured out what helps with their pain. So I love to hear from people like that.
Isn't that great? It's such I think it's a wonderful thing to discover what people are doing on their own, as you put it. Yeah, being self-inventive. People are curious and clever and finding ways to highlight that and ask those questions. I love that you're asking people those questions, because then that becomes information for other people that we never, it fascinates me how much information is out there that we will never have because nobody is looking for accolades. They're just developing something to get by. And if they happen to tell a person, that person knows about it, but they may never tell anybody. And there's whole teams of people working up research questions and trying to fund studies and things that are trying to find answers to questions that are out there. So I love that you're talking to people and soliciting that information from them. I'm going to put, you had been kind enough also to provide me with links to some of your research and articles too, and I'm going to put those in the show notes, the show description, and I will say anybody, depending what podcatcher or program you use to listen to your podcasts, sometimes those automatically hyperlink, and sometimes you have to copy and paste or just look at the notes to see them. Either way, they'll be in there because this is a very important. As anybody knows, I talk a lot about addiction, a lot about dependence and overdose risks, but also a lot about chronic pain and that management too. There's way too much research and treatment that has been put into the cognitive behavioral psychological approach, and it's way too effective for us to keep pretending it doesn't exist.
Yes.
So, all right. Well, thank you so much, Dr. Wilson, for being here.
Thank you. And thank you so much for letting me share today.
Thank you for listening to the Court and Parts Podcast Network. To listen to more Court and Parts shows, visit courtandarts.com.